I just have a quick question, Rogan, and also Dr. Bittinger. What is the goal in the next 6 months? I think a lot of people just want to know, when can they just start getting back to normal? So Massachusetts has almost 7 million people. How much of that needs to get, how much of them need to be vaccinated for things to just kind of get back to normal?
So the committee said quite explicitly that it is our explicit goal that everyone in the Commonwealth who is medically eligible receive the vaccine as soon as possible based on the supply we have. That is definitely our goal. We recognize there will be those who may not wish to go at the first wave. We also recognize there are parts out of our control with the supply chain. But the goal is really to vaccinate every medically eligible person. In terms of your question of when things get back to normal, there's a lot of science that looks at this. People know the term herd immunity. We definitely have to get to a majority of the population who has effective immunity before we can get prevalence of the disease down low enough that we can get back much closer to normal. So again, the goal is as quickly as possible. Definitely more than, I would say, 60% is where the models are, but from our perspective as a committee, we want everyone to get it. That's how we will protect lives throughout the rest of this pandemic.
Is there a timeline for that? I mean, do you expect to get it?
There's so much dependency on external supply, I don't think we can say, but as soon as it arrives, I think we're committed with the Commonwealth, with others, to get it out as quickly as possible.
Dr. Bittinger, could you speak to the additional 20%?
Sorry, the trust factor, that's going to be a huge hurdle for all walks of life. If I'm not mistaken, you've got Dr. Fauci to come talk to your congregation. What in that conversation really led some of your parishioners to understand this is going to be a good situation? What was it the education, or was it just the trust?
I think that most people were impressed that Dr. Fauci showed up to speak directly to a community. We had 2,800 people who registered for this talk, and while some of them were not directly from my community, I have talked to enough people who believe it was the idea that he was there. He showed up. I think he also spoke directly to the issues of historical, racism, historical issues with getting health care. So he was very clear and direct and focused in his statements about the problems we face. And I think a lot of people really appreciated that from him.
And what did they say afterwards? Did they say thank you?
Well, I've only done anecdotal kinds of polls among my parishioners, and I have, of a few, I'd say fewer than 20 people, half were impressed with Dr. Fauci and thought they would consider it. Half were still very skeptical. I think that that's probably indicative of a lot of people in our community, though I have read polls that say more people are up to taking this in the Black and Latinx communities. But I think there's a lot of skepticism still. It's going to take a lot of work.
Dr. Bittinger, could I ask you a question while we have you? I'm assuming this is perhaps a loss for Mass General, a gain for the nation. But could you react to Dr. Walensky being named the director of the CDC?
So I can't think of a better person to be in this role. A smarter, more compassionate person whose whole career has been driven by scientific analysis of policy, who's a great communicator. I think for me, for the Governor's Advisory Group, we will miss her tremendously, but I think it's a clear win for the nation.
Dr. Bittinger, I have a question. How closely are you paying attention to what's happening in the UK with the Pfizer vaccine, prompting this warning about allergic reactions?
So we watch things extremely closely. Obviously, they have now a couple days experience heading into this. I believe the data from what happened in the UK will be evaluated by the FDA's Vaccine and Related Biologics Project Advisory Board tomorrow. So I think we'll be following it extremely closely. I would note that we did see a small incidence of allergic reactions in the trials. We see allergic reactions to therapeutics, unfortunately, of all kinds. And so what still bears watching is whether there's a statistical significance, whether this is more than would occur with placebo or with other vaccines or other therapeutics.
And has the board given any thought to some sort of vaccination passport or some proof that, hey, I got vaccinated, I can go to a concert?
So I think so much of this depends on sufficient levels of community vaccination. So I think people should expect that we all have to be following the guidance that's been so well stressed today for some time until we get large numbers of the community vaccinated.
Doctor, a practical question on the vaccines. Assume someone's in the first group, gets the first vaccine, the second vaccine. Everybody else is not going to get it until the summer. Do those that are in that first round, do they still have to wear face masks for another 6 months or however long until it's deemed that it's safe? Or are they good to go?
So what we know about vaccines is that they dramatically lower your risk of needing hospitalization or dying. They protect you. What we don't know is whether they completely prevent you from getting a low-level infection or transmitting the illness. In other words, I could be vaccinated, but I could have a cold maybe so small I don't notice, but that means I put others around me at risk. So until we get to high enough levels of vaccination, we need to be following the same guidance altogether. I can't take my mask off because I've been vaccinated. It's why we're all in this together and need our vaccines.
Dr. could you speak to or elaborate on the additional 20% that you guys said would go to sort of disproportionately affected communities? Is that 20% of communities as far as general public distribution that would happen between April and June? Or when in the process is that going to happen?
So I'll defer to the state on the mechanics. The CDC's guidance to states suggested that they could set aside a portion for special allocation to the most at-risk communities, in this case 20% for those based on social vulnerability index and prevalence of COVID in those communities. That 20% of the state's allocation can go to those communities, and 80% goes to all the other groups in the same order. Secretary Zek, would you like to clarify?
Actually, that was a good answer. So two ways to think about the equity. One is that I think, as you heard, about the prioritization of the groups. And so when we think about, I'll answer the question, healthcare workers in COVID-facing works, work was to ensure that, in addition to it being the direct care staff of nurses and physicians and the like, also would include dietary environmental services staff. So really trying to take a broad lens of what is healthcare direct COVID-facing work. I think that part of that is an equity lens. When you think about home health workers, very much disproportionate individuals of color, right? Personal care attendants, home health aides, and the like. So as I understand the advisory group, as they're advising the Department of Public Health, that the equity lens really was one of the primary focus of thinking about the preservation of life, addressing comorbidities, preserving our healthcare system in a lens of equity. And then as the CDC said, you could allocate additional to address disproportionality. So 20% to the communities in sort of that third phase as we're doing the general population to really ensure that those communities, we have 351 communities in Massachusetts, to really ensure that those were so disproportionately impacted, have high rates of socioeconomic status. Sorry, I have a frog in my voice. Housing, number of individuals in your family, minority status and the like, that we ensure we have balanced that out with this extra allocation.
So aside from the 20%, I guess just to make sure I understand it correctly, that's in addition to, there could be some overlap with some of those
there is definitely, anyone who looks at the prioritization, as you heard, like younger people are in sort of the general population, but if you're obviously a home health care worker who is a young person, you're going to be in that first prioritization. So people should see these prioritizations for what they are, right? But they're not rigid. It doesn't mean any young person is in phase 3, because obviously we have a lot of people who are young who work in direct care, home care work, hospitals and the like.
Do we know roughly how many people are in phase 1? And given the prevalence of COVID in some of those populations, including long-term care settings, is the recommendation that people who have been infected already also get the vaccine, or is natural immunity enough?
So I'm going to turn the natural immunity question over to Dr. Bittinger, and I'll come back on the numbers. How's that?
So the current recommendation we believe is coming from CDC will be that anyone who's had a documented case of COVID in the past 3 months, wait until that 3 months has passed before receiving their vaccination when their time comes in the phasing. But everyone else, if they've had documented COVID longer than 3 months ago, still be vaccinated. The data suggests that it's still protective even if people have had diagnosed COVID before.
Glasses. Just wait till you get to be my age. So again, these are, ballparks. So clinical, non-clinical healthcare workers doing direct and COVID-facing care is about 170,000 individuals. Long-term care facilities, about 115,000. Police, fire, emergency medical, 50. Congregate care settings, including shelters and corrections, is about 88,000. Home-based healthcare workers, including the personal care attendants, of which we have 40,000 in Massachusetts, about 115,000. Healthcare workers doing non-COVID facing care. Matt, you're going to have to do the addition because I don't have a total at the bottom of this. 130,000. And then we think individuals with 2+ comorbidities is about 650,000. Critical workers such as early education, K through 12, transit, grocery, food and ag, sanitation, public works, public health workers, probably about 840,000. Adults 65+ and individuals with comorbidity, about 1.1 million. And then all others, about 2.785 million. That gets you up to about 80% of the population of Massachusetts.
So would the nursing home staff and patients all go at the same time?
Yes, so nursing homes, so the federal partnership with CVS and Walgreens is staff and residents. And it is the allocation of the vaccine is to CVS and Walgreens, and then they are responsible for the administration of the vaccine to residents and staff.
So that's a lot of people, obviously.
I'm sorry?
That's obviously a lot of people. And, in your best estimate, I'm asking you to look in your crystal ball, because I know something don't.
It's pretty, in a pandemic, crystal balls don't really work.
Well, I think a lot of people just want to know, if next year at this time, are we all still going to be wearing masks, in your best estimate?
You know what, I'm going to hand it over to Dr. Bittinger about herd immunity, I think.
So with all the caveats that we are dependent on all of the vaccines in the supply or in the research pipeline receiving an emergency use authorization, the production being uninterrupted, we believe that in 6 to 9 months we should have reached a good chunk of the country. It's hard, a good chunk is clearly not a nice number, but I think we can make substantial progress at vaccinating a large portion of this country, a large portion of this Commonwealth, if those caveats hold true. Lots of caveats, unfortunately, in there.
Doctor, how challenging are those side effects with the second dose in terms of, do you have any advice for these agencies dealing with frontline workers? You don't want them all out sick for a day on the same day?
So I think it's really important to talk about the potential side effects of the vaccine and what they are and what they mean. We know that people may have fatigue, may have muscle aches, may have headaches. A small number may have fevers. And those are relatively mild and relatively more common in the second dose than in the first. Only a small number of people we expect, based on what we've heard so far, will actually feel ill enough to need to stay home. What it represents is the body's immune response. It's a good thing. You're developing the immunity. So much as, of course, none of us would like to have some muscle aches for a day, they're very transient. In some of the studies, they've been over in less than 24 hours. And again, it means that your body's having an effective response. We understand that the CDC right now is working on criteria for when healthcare workers might need to stay out of work because of those symptoms versus when they can continue to work within the first 3 days. So I don't want to ignore the symptoms. I think it's much better when people know what to expect when they've received a vaccination, but understand that those are good things, and the number of serious vaccine-related events really has not been seen in the trial data we've seen.
Doctor, what about to show to get the vaccine? And if there's some sort of identification required, has the board given any thought to undocumented immigrants?
The advisory group felt very strongly about equity, as the other speakers have mentioned, that the residents of the Commonwealth all deserve equal access to vaccine. And in terms of right now the first wave, which is the farthest in the future I can speak right now, people who are in these congregate settings, staff already, we know who they are because they're getting vaccinated through those places.
What about the supply of the vaccine? I know the government had huge headaches with PPE supply early on in the pandemic. How do we make sure that we have enough coming in? Is the state's going to be fighting for it?
So in terms of things like needles and syringes and others, those are actually included in the allocation from the federal government to the vaccinating sites, and they have procured very large amounts of those supplies. So certainly, again, supply chain of the vaccine itself is an unknown, but so far the indications have been encouraging.
Dr. I don't think this comes up a lot with other vaccines, but I don't think we pay as close attention, but has any thought been given or planning done as to what might happen if additional vaccines get approved and say the Pfizer vaccine is 90% effective and the AstraZeneca vaccine is only 70% effective and people start requesting one versus another? Would that be accommodated?
So I think in the early stages, practically speaking, no. The two vaccines that we're anticipating in an emergency use are essentially equal, 94.5% effective. I think what we have been talking about is there may be different profiles in different patient populations. So it may be that one is especially good or maybe not as good in the elderly, as one example. There may be a time when we tailor what we do, but I think, again, we actually limit an enormous amount of death and disability in this country with flu vaccines that are certainly much less effective than the high numbers we're talking about now for the COVID vaccine. So there's still a definite role for these.
But are you worried that people might refuse to get what might be seen as the lesser vaccine?
I think it's all about our communication strategy, and I don't want to speculate because there's so much that could evolve in that arena.
Doctor, can I take your question on ICU capacity?
Sorry.
Are you concerned at all, Doctor, about the cold storage chain? I had an expert tell me Pfizer is shipping 1,000 units in a pizza box covered by dry ice. When you open it, you might need to have the people ready to get 1,000 doses. Is that a concern?
So they've been extremely specific in how to handle these pizza boxes, how long they can. I'm sorry.
They are shaped
Fair enough. I should not. Yeah, no, it's a really important point. It's been engineered for this purpose, right? So it is not, in fact, a pizza box. It is a specifically designed, purpose-built container with very technical requirements about how long it can be open and when it needs to be refilled. So I have a lot of confidence that we should be able to keep the vaccine at the appropriate temperature.
Even smaller hospitals, that might not be set up like Mass General. You feel confident they'll all be ready.
So the product can stay for up to 5 days at refrigeration temperature. I think with good supply chain management, yes, absolutely, this can be done.
Doctor, you mentioned that experts will be watching closely potential reactions. Are there any particular allergic reactions you'll be looking at? And when you look at those, how do you explain to people that these might be normal or the severity or lack thereof of those reactions when people have heightened fear about vaccines?
So everyone who receives a vaccine will actually receive a printed sheet to let them know what to look for in terms of adverse reactions. There also are 9 different data monitoring systems, including an app that will be available to people on their smartphone for reporting adverse events. And so all of this is being rolled out. We look at individuals' reports, we look at hospital system data, and basically we know what the adverse side effects of vaccines have been historically. We're looking for every one of them.
Doctor,
Last question.
The governor mentioned, if I heard him correctly, 6 weeks between the 2 doses. I've heard 21 days.
So to clarify, the 6 weeks refers to, on average, when we think people will have effective immunity at high levels. The repeat doses are actually different from vaccine to vaccine. So for Pfizer's 21 days. For Moderna, we believe is 28 days. We're not sure for the others that will come, but almost all of them we believe will require a second dose. It'll be different depending on the product.
Is there a security aspect to moving the vaccine? Will UPS and FedEx know that they're moving this?
So I know lots of people have thought about that and are carrying. We move around controlled substances all the time in the medical world. I think we'll definitely be in good shape.
Secretary, could you talk a little bit about jails, prisons, homeless shelters? I think some people have some questions about why those populations need to be in phase 1.
Well, actually,
Or whoever.
I should leave it to the advisory group because I was thrilled with the recommendation, but they're.
So I think congregate care settings where individuals are closely together, we know are a documented risk factor, not just for a single individual, but for large populations being exposed to COVID and becoming ill at the same time. And again, from an equity perspective, where people are together and at risk in the same situation, we felt it was really important to prioritize that group.
Governor, federal data, Governor, shows that hospitals' ICU units are approaching capacity. Are you expecting for that to happen, and are you prepared for them to reach capacity? And how concerning are these numbers to you?
Well, part of the reason, first of all, we've been doing calls with the hospital community either 2 or 3 times a week or every day now for 10 months, and we talk about bed census and ICU census in every single one of those conversations. And I can tell you that on the last call we had, which was very recent, one of the things the hospitals, almost to a facility, talked about was the fact that they are not seeing the same level of ICU percentages as a percent of the people they're actually serving in hospitals generally as they saw in the spring, and that the length of stay in the ICU was dramatically shorter now than it was in the spring. Generally speaking, most of them are running somewhere in the 50 to 60% total occupancy at this point in time, and I think our current hospital occupancy on ICUs is around 300. It was over 1,000 in the spring. So what I would say is, look, the whole point behind the decisions we made with respect to elective procedures generally and sort of economic activity and mobility are all driven in large part by concerns about trends across the hospital system, and those have been exacerbated a bit by the number of staff who have been exposed, who are out and quarantining until they can come back. So we remain confident that our system has a lot of capacity in it, but we are concerned, and that's why we made a number of the decisions we made in the past 4 or 5 days.
Governor, if I'm reading this right, phase 1, your dad would be phase 1. Have you talked with him about the vaccine? And do you have any qualms about him being among the first?
I have not talked to my dad about the vaccine. Honestly, we talk about much more familial stuff when we talk, for a lot of reasons. Wasn't expecting that.
Any qualms?
I don't have any problems with it at all. Obviously, he's a big boy, and he'll make whatever decision he thinks is in his best interest, but I would certainly recommend to him that he get vaccinated.
Governor, there's been some reporting out there. Should or could employers force people to get a vaccine if they want to come to work? I don't know if the Attorney General has looked at that at all, or whether you know whether that's proper or not.
I've talked to a lot of folks in the employer community, and in fact, I did a call this morning with a bunch of folks in the employer community about a whole bunch of other issues, but this one did come up, and honestly, the overwhelming sentiment I got from the entire employer community, we're talking tens of thousands of employees on the group that I was talking to, is people want to provide information and advice to the extent that they can to their employees, the same way they would with respect to other issues, but nobody's talking about, we're certainly not talking about a mandate, and I sincerely doubt you're going to find anybody in the employer community talking about one either. But I do think people are going to want to make sure that if they can provide guidance, provide information, push people to trusted sources for data and information, they're going to want to do that with respect to this as this all plays out over the next 6 to 9 months.
What is shaping up to be the biggest challenge with the distribution? What is shaping up to be the biggest challenge?
Well, I think challenge number one, and I think Dr. Bittinger talked to this quite specifically, is the lumpiness associated with the beginning, right? Because what most people in the space have said is the biggest question here is not so much whether or not when people ramp, they will ramp aggressively. Most people believe that they will. The biggest question is when they actually get to the point where they start to ramp in terms of manufacturing. And on the distribution piece, I would just say, this is a good question, maybe I should punt to Dr. Bittinger. This is very similar to how we manage vaccine distribution every year in Massachusetts, with two differences. One is it's a much bigger number in the grand scheme of things than we typically do. It's a double dose. I thought it was 21 days too. I don't know why I'm going to have to talk to my speechwriter. It is a double dose, and the other issue is you have particular populations that we're all trying to focus on first. But my expectation is that people have a sensibility about how to make this work, and I think I will let the chair speak to that one.
I mean, I think people's thirst for knowledge about this vaccine and what it means and where it came from and how much of this is different from vaccines that we give our kids and we all take for flu each year is really important to understand. And so we're trying as hard as we can to put out enough information that people feel confident in getting the vaccine. We want people to understand the rationale for why we are trying to allocate in the way we can. And again, the committee said very specifically, if we had enough vaccine on day one, we would want to give it to every eligible member, every eligible resident of the Commonwealth. We can't do that. It's obviously not physically possible. So we have to think about it in the way that rationally saves the most lives, protects the healthcare infrastructure, and really promotes equity.
Dr. Bittinger, does the K-12 distribution include 18-year-old students or plans to include younger students if a vaccine candidate is approved that works or is safe for younger people?
So right now, we don't know about what the indications for pediatric population will be from the emergency use authorization. So I think we just can't say what the indications will be in the pediatric population.
But for the 18-year-olds in the K-12 population, are they included?
So 18-year K-12 refers to the instructor community, the teacher, the school staff. And so 18-year-olds would be covered otherwise in the population group that they're appropriately covered in.
Sorry, just to clarify, the final roundup mentions, I think when you count it up, it's like 5.85 million as opposed to maybe closer to 7 million. Is that because of these children who are not able to get the vaccine right now, or?
So that represents about 80% of the population, which is individuals over the age of 14. It's an estimate because, as Dr. Bittinger said, we don't know what the EUA is going to say in terms of the pediatric population.
Governor, was the city manager tested positive for COVID? I believe you were with him last week. Were you contacted as a close contact in any way, or were you taking any additional precautions yourself at Augustus?
Yes.
I haven't